My name is Chad Glenn. This is the accompanying PowerPoint for the chapter Craniopharyngioma in Adults. The objectives of today's talk include understanding the topographical classification of craniopharyngiomas, determining the goals of treatment for adult craniopharyngioma, and reviewing the current treatment options as well as future directions. Craniopharyngiomas remain as one of the most challenging intracranial tumors to manage. This is due in part to the tumor's location as well as the morbidity associated with treatment. Advancements in surgical technique and endocrinologic care have reduced the perioperative mortality rate to less than 5%. However, even with these advancements, these tumors still carry a significant risk of postoperative morbidity, as well as recurrence even following gross total resection. Craniopharyngiomas are benign WHO grade 1 extraaxial tumors derived from epithelial cell remnants. These tumors represent 2 to 5% of all intracranial neoplasms, with a bimodal age distribution observed. Two major histological subtypes exist: the adamantinomatous and the papillary subtypes. Adamantinomatous tumors are most common overall, seen in both adults and children, while papillary tumors are almost exclusively observed in adults and represent 14 to 50% of adult cases. Beyond histology, advancements in molecular pathology have identified unique genetic alterations in each of the major subtypes. Adamantinomatous tumors harbor activating mutations in exon 3 of CTNNB1, resulting in dysregulation of the Wnt beta-catenin signaling pathway. Papillary tumors harboring mutations in BRAF V600E, which drive signaling through the MAP kinase pathway. The surgical approach for craniopharyngioma resection is determined based on the tumor's relationship to surrounding neurovascular structures. Over the years, numerous classification systems have been proposed based on the relationship to the optic chiasm, the diaphragma sella, the third ventricle, and the infundibulum and pituitary stalk. More recently, advancements in endoscopic and nasal surgical techniques have expanded their use to include craniopharyngioma resection. The optimal surgical approach is determined by the above-mentioned anatomic relationships as well as the surgeon's experience. The following is a proposed algorithm for determining the optimal surgical approach based on the tumor's location. To start, tumors that are primarily located within the sella are often amenable to an endoscopic endonasal transsphenoidal approach. Similarly, tumors that are primarily located within the ventricular space are often resected through an interhemispheric transcallosal approach. For tumors with a postfixed chiasm, frontotemporal orbitozygomatic or extended endoscopic endonasal approaches are often selected. For tumors that are located retrochiasmatic, multiple approaches have been described. Once the optimal surgical approach has been determined, the goals of treatment must be defined. The goals of craniopharyngioma treatment is to provide tumor control while minimizing treatment-related morbidity. To this end, two primary treatment strategies have been described. The first includes aggressive surgery with a goal of gross total resection, while the second favors subtotal resection followed by adjuvant radiation. The literature has over the years been able to provide the surgeon with some important considerations when treating a patient with craniopharyngioma. The initial surgery is the most critical time point in the course of the patient's treatment. This is because with each intervention, the morbidity is cumulative. That being said, the resectability of the tumor diminishes with each subsequent operation. Furthermore, gross total resection may afford improved long-term tumor control. However, this may be at the cost of increased surgical morbidity. Noteworthy extension of the tumor into the suprasellar space is associated with worsening endocrine function when gross total resection is attempted. Smaller tumors with less suprasellar involvement may be amenable to gross total resection with less morbidity. Early tumor recurrence is more common following subtotal resection than gross total resection. However, recurrence following gross total resection has also been noted. Some studies have suggested that long-term outcomes, including progression-free and overall survival, are comparable regardless of whether the patient was treated with gross total resection or subtotal resection followed by adjuvant radiotherapy. Traditionally, craniopharyngiomas have been treated with a combination of surgery and/or radiation. In more recent years, emerging evidence has suggested a role for BRAF inhibition in the setting of papillary craniopharyngioma. Though limited, some reports have demonstrated dramatic responses in some patients. At present, BRAF inhibition may be considered in the recurrent setting after molecular confirmation of BRAF V600E mutation. Future study will delineate the role of BRAF inhibition following subtotal resection of papillary tumors. In summary, craniopharyngioma is an uncommon and benign tumor occurring in both adults and children. Papillary craniopharyngiomas arise from the BRAF V600E mutation, which drives signaling through the MAP kinase pathway. Emerging evidence supports consideration for BRAF inhibition in the recurrent setting. Dysregulation of the Wnt beta-catenin pathway is found in nearly all adamantinomatous craniopharyngiomas. The morbidity associated with the tumor itself, as well as the selected treatment, is directly linked to the tumor's location, with associated cognitive, behavioral, visual, and endocrinologic sequelae. For most patients, surgical treatment will be necessary at the time of presentation to relieve symptoms. The initial surgery is the most important time point in the course of the patient's treatment, as each subsequent treatment results in cumulative morbidity. When safe, gross total resection may result in a higher rate of long-term control, but surgical aggressiveness is associated with increasing incidence of surgical morbidity, which may significantly decrease the patient's quality of life. Subtotal resection may be associated with less upfront surgical morbidity, but this may be at the cost of lower rates of early tumor control, requiring additional treatments. Lastly, surgery remains the standard of care for patients with craniopharyngioma, with the role of radiation used more commonly in the recurrent setting. Current clinical trials are examining the use of proton therapy as well as BRAF inhibition in the treatment of adult patients with craniopharyngioma.